Welcome, everybody. My name is Nasuh. I'm director of our child psychiatry service, and I have the great privilege of introducing our speaker today, Dr. Nancy Rappaport, who will be speaking on school threat assessment, school violence. But before we get into that, I do want to provide some announcements that we routinely offer for Grand Rounds. First of all, I wanted to remind you, if you're a psychologist or a social worker in the auditorium, to please sign in and out of the lecture on the sheets that are provided in the atrium. This is something we need to do in order to have you receive CEU credits. Additionally, psychologists and social workers must complete their evaluations to claim credit on the MyCME within 1 week of the lecture. For those that are on virtually, if you could reference the chat, Fawn will be placing the activity information sheet there for your reference. Also, I want to remind everybody that's on virtually that if you can use the Q&A section rather than the chat section, use the Q&A to provide questions. We will monitor the questions. We try to take some questions in-house first, but then we'll try to review and see if there are virtual questions as well that we can address during the talk. So I do want to introduce Dr. Rappaport, and this is actually a very extensive profile, so bear with me. It'll take a few minutes to go through. Well, I do want to give you justice, and also I think your story is phenomenal. So Dr. Rappaport is a graduate of Princeton University, and following her graduation at Princeton, she actually worked as a science teacher in Harlem. And that work was really inspirational for her pursuit of medicine and her work in schools. It was actually the foundation for a documentary called the Children's Storefront documentary that was actually nominated for an Oscar as Best Documentary in 1988.
A long time ago. And it was a short documentary.
So then she went on to pursue medical school and did her residency at Mass General and pursued a fellowship at Cambridge, became child psychiatry trained, and spent over 25 years doing school threat assessment and conducting research, education, training, and clinical care in collaboration with schools. Her work was recognized by the American Academy of Child and Adolescent Psychiatry Sidney Berman Award for the school-based study and treatment of learning disorders and mental illness in 2012. She's also the author of The Behavior Code, a practical guide to understanding and teaching the most challenging students, published in 2012 with another behavioral analyst, and also published a very compelling and very intimate story through her memoir, In Her Wake, A Child Psychiatrist Explores the Mystery of Her Mother's Suicide. This received the winner of the Boston Authors Club 2010 Julia Ward Howe Prize. She's also been very innovative in getting her message across and actually wrote a play called The Regeneration, a powerful narrative tool. And I learned last evening she's also working on a novel. So really just a phenomenal individual. I've been to her workshops at ACAP, have learned so much. But you don't want to hear from me, you want to hear from her. So without further ado, Dr. Rappaport.
Thank you. So I've been so well taken care of since I got here. I mean, go Michigan. I mean, this doesn't happen on the East Coast, you know, that people meet you for dinner and they have breakfast with you, and then I get to meet with folks afterwards. And hello, Zoom people. I wish you were in the room with us, but I'll try to keep us all connected. So, first, before I launch into what my talk is, and if you were thinking you were going to talk about like the football team, that we're in the room where we're talking about safety assessments and how to think about this. And I just want to give context when I'm talking about people like to call them threat assessments or safety assessments. And I have worked in schools for 25 years, public schools. And one of the things that I certainly have invested in is primary prevention. So I worked on an advising program for 6 years where I had 2,000 kids and 200 staff. So primary prevention is incredibly important. I also worked at a school-based health center for 23 years, embedded in the school, so kids really didn't have to go far to get support. But what we're talking about today is tertiary care. And this is just a visual of sort of like trying to teach kids how to swim, or in some of our primary primary prevention, it would be SEL, if you've heard of that, social emotional language, and then building on to giving a life jacket would be secondary care, and then there's tertiary care. Threat assessment is a fact-based investigation that focuses on an individual's pattern of thinking and behavior to determine to what extent they are moving toward an attack. So that sounds very sobering, and the good news for you all is that targeted assessments are relatively rare, but we want to be able to make sure, I want each one of you, when you leave this, it's like we're opening up the window and getting you to think about this process, and that there are resources you can go to that are free online. My website is very accessible, and you can download, just put in safety assessment and get articles, so that if you're in the emergency room, if you're an inpatient doc, that, we do have a forensic psychiatrist here who's an expert within your staff, Katie, but that you also know that there are written materials to support you in figuring out with your patient, is this something where I need to make sure I get shared responsibility and get some extra help with thinking about this. If I asked you just in a poll, what do you think the percentage of school violence, where does it happen? What we see is that 52% take place in residencies, 30% take place in parking lots or in roads, and 1% to 2% take place in schools. So it's a relatively rare event, but because especially, and of course, even in Michigan, when we had the school shooting recently, it mesmerizes people. We gravitate to the loss of human lives. And the next slide is really very upsetting in a way. What you're seeing is each circle is 10 kids that are exposed to gun violence at school. And each larger one is one event. So you'll see various, major events that have happened, like Sandy Hook. But what's striking is that more than 356,000 students have experienced gun violence at school since Columbine. That is a stunning amount. And to bring it home, I just wanted to read to you, I've had 2 Harvard freshmen in my freshman seminar course that I do on psychiatry and memoir come in who've been impacted by school violence. That's there are only 12 people in that seminar. And one of the students wrote about, and she gave me permission to share this, I pulled into the school parking lot. Hey, Amanda, what's up? Holy shit, some autistic boy stabbed a kid and he might die. The morning is January. That afternoon, the quote-unquote kid that was stabbed, James, died from fatal wounds to the chest and the shoulder. And the boy who killed him was handcuffed and taken to jail, and our school was put on a lockdown for the day. The news said, tragedy in a small town, same old story. And she goes on to the reputation of the student who had killed the other student as the bizarre guy who wore a trench coat and fedora. He was awkward in social situations. He didn't have many friends. He would go up to random people in the cafeteria or hallway and start blabbering on and on about his interests. One interest, his favorite by far, left people feeling a little unsettled once the conversation was over. He loved weapons, guns, knives, grenades. And as a freshman college student, she asked, we all knew he was obsessed with weapons. Part of it wasn't a surprise. Everybody knew. And what I'll tell you about later is that this was a district that it's a wealthy district, and thought it's not going to happen in my school. And so even though there were many concerning things, it did not mobilize. So I think of each one of you as an ambassador. It may be that you have someone come into the emergency room, and I met with Victor last night, and that's possible that in the emergency room you'll have something where you're not doing what I'm talking here about, doing a threat assessment, but that there are red flags that are brought up that would make you prompt to have them go into the inpatient unit. It may be you're on the inpatient unit and somebody comes in. It may be that you have an outpatient patient that is sharing information, or you're being asked to help with the aggression that a student is showing in the school. So that's what I'm asking you all, is be an ambassador. So here we go. So what we're going to cover, and my hope is that we will talk for another hour, and then that we will have 15 minutes for opening up for questions. So hold on to somebody that by what I'm covering, it may prompt you to have a question about a patient that you're treating, and I'm happy to answer that. And I know that I'll be meeting with residents afterwards too, so happy to explore it more. So what we're going to cover is, what are schools doing in the name of prevention and deterrence right now? What kind of safety assessments work? How do we work with schools to create a reflexive process to enhance safety and support families and students? And how can you act, each one of you, as a well-equipped safety ambassador in your community? So what are schools doing in the name of prevention and deterrence right now? So sometimes when I talk, I want to emphasize that I am incredibly respectful of our educators. They are in the front line right now. And all of us should bow our head in humility with the level of perseverance that educators have shown. That said, there's ways that we, as school systems, end up failing our kids. And one way is that we have flavors of the month. So you can track sometimes, I forget who it was, Tom Hanks or somebody, who said, follow the money. You can track in schools sometimes how it goes from, 5 years of bullying because there's 5 years of grant money. Now we're into anti-violence stuff that will end up, and it's unfortunate, right? We need to have sustained attention to the complexity of the problems that we're facing. So, the other thing I would say is zero tolerance doesn't work. That was a policy, for those of you who aren't working in schools, where there was the decision, if we just expel folks from schools, that will help us. It's interesting, when I was doing research about Michigan, is Michigan stopped the zero tolerance in 2017, but they've actually had an uptick in expulsions, which I just find sort of fascinating to try to untangle how that would happen. And the other piece is that this is from the ACLU report, Cops and No Counselors. And one of the problems that we have is that we often have a disproportionate amount of money that is spent on lockdowns and school resource officers, and the fact that we have 25% of schools that have no psychologists and or social workers in our country is a stunning statistic. And so lockdowns, lockdowns are not effective. There are no, so this is a place where you can be an ambassador. If you have kids in schools, they may come. I was just encouraging people to ask your school, if you have kids in schools, how many times are you doing lockdowns? Ask your patients how many times they're doing lockdowns. You have a patient that comes in with anxiety. Are they, because imagine with a traumatized kid that you're asking them to do a simulated school shooting, or to go through the exercises. And, the traditional lockdown was turning off lights. Now we've gotten into somewhat more absurd kinds of practices. Alice, which is something again, speaking to you all as advocates, I've tried to speak to any reporter that will talk to me about. Alice is a lockdown system called Alert. Oh gosh, I'm gonna have to get hold on, let me just make sure I got the Alert. I'm gonna have to just is Alert, Lockdown, Inform, Counter, and Evacuate. And counter, tell me that you're going to have and they have this, a second grader counter a semi-automatic weapon. I'm sure that would have helped with Sandy Hook. So this absurdity that when we know from Parkland that even a school resource officer who had a gun was intimidated to go into to look for the gun shooter. We are living in a time that is, doesn't make a lot of sense sometimes. And my mantra is human detectors, not metal detectors. That what we want is connectedness. That's critical for supporting people. I had a factoid of Michigan in terms of what in Fruitport, Michigan, there's a town of over 1,000 people announced that it was spending 48 million to redesign the high school campus. And how were they going to do it? They were going to minimize casualties by having a curved hallway to shatter a shooter's line of sight. They were going to have hidden wing walls so that to shorten a shooter's line of sight to hide, an alarm and lockdown system to isolate a threat at the touch of the button. So we as a country are spending $3 billion on safety measures, which I think, as you were talking about, are sort of, they give you this, the misguided perception that you have safety. And so what kind of safety assessments work? So rather than fortifying schools, I think we want to be putting the emphasis on providing threat assessments. And if you just look at this picture of this very cute dog and then this sort of snarling dog, it's me prompting you to ask, when you think of safety, what do you think? And when you think of a threat, what do you think? So one of the things that I would encourage with, if you're on a inpatient unit, is really for us, or outpatient, to think about the quality of the language we use. Because I have really proposed that we call these safety assessments versus threat assessments, because it puts the emphasis on, first of all, that we can't predict violence. And second of all, that it is both about us recognizing that many of these threats are transient, but they're signaling trouble in a child. So we want to be able to mobilize to support the families and the child. And I've been working 23 years. I did safety assessments, and I've been supervising and teaching about doing these assessments. And when I talk about a threat assessment, it may be that there's a threat to a teacher or a fellow student. It may be that students have destroyed classroom property, posted an image on internet that is potentially threatening. And when you have the luxury of either being a forensic psychiatrist, psychologist, or consulting to schools, or sometimes on inpatient units, what you want to be able to ask, and certainly in schools, this should be happening. You want incident reports, academic transcripts, psych testing, the IEP, the individual educational plan with collaterals, and get permission to be able to talk to outside clinicians, probation officers, and most importantly, having collaterals, being able to interview the student, the school, and the family. So what's really tragic is whenever we have a massive school shooting and studies are done, what we discover is these were missed opportunities to intervene. You know, and whether we have at Sandy Hook in 2012, Arapahoe in high school in 2015, the Marjorie Stoneham Douglas High School in 2018, and the Robb Elementary in 2022. And I would wish I mean, I think Seligman said learned optimism is about persistence, but it's actually really sad for me. If you look at some of my writings in local NPR Cognoscenti, it's almost as if I could recycle my plea for us to set up systems to be able to provide support to our schools. These are all the different reports. Okay, this is probably one of the most important slides to you all. This is done by O'Toole, who is part of the Department of Ed and the FBI effort in to bring for the Safe School Initiative. And this is the $1 million question. The $1 million question is this just a typical impulsive kid who wants to get attention? Or is this a kid who has concerning behavior where we need to mobilize to support him? I come from a high school where I worked, where a very famous actor who will remain nameless, in 1985, I have a bootleg video where he did Broadway Nightmare. And it was basically his senior project was to stage a school shooting. That was pre-Columbine. He did not get expelled. He went to a pretty good college, a very good college. I'm not going to let you figure out who it is, except for I'm from Cambridge. Do the study. But that's because at that time we had much more of a tolerance for impulsive, stupid behavior. Now that would get him expelled. That would torpedo his education. So context super matters. And so I would also say, as ambassadors to your patients, I think every one of you should review with your patients the weapon policy in schools, and particularly the weapon policy with your ADD impulsive kids. I've had kids who have not been able to go to school because they had a jackknife on their key belt, on their keychain, and that a security saw it, and then they're out. And so that idea of, or telling a kid that that's impulsive, who has problems with anger, that they should make sure when they're gaming not to put a threat around the schools. You'd think, oh, well, that's obvious, but it is not obvious. And I've done assessments where it may be a transient threat, but it still builds, it gets them into major trouble. So the concerning behavior, the ones that I want to highlight, first of all, are the bizarre statements of behavior. We know that in the work that Langman did, that 35% of shooters that he looked at between 1975 and 2011, 48% of them had delusions, hallucinations, and severe impairment. So what's important about that is sometimes in your high school age, you will have kids who are prodromal, who are an early psychosis just starting to show up. And being able to get in there early and intervene is incredibly important. And incredibly important also to support those students, because sometimes they might not be actually going to execute their plans, but they're talking in ways that are very scary. And being able to both identify them and protect them and get them into care is really important. The warrior mentality is something that is important. But then the next one that I wanted to highlight here is the agitation. So agitation is both something that can get you into big trouble when you're suicidal, but it's also something that's a real trigger for when you have kids that have concerning behavior, where you really want to, particularly if you have someone in the emergency room that's talking about agitation, not sleeping, and there's concerns about their aggressive behavior, of really thinking about containment as a way to do a further analysis. So the Safe School Initiative, as I mentioned, was something that was brought together by the FBI, the Department of Education, and the Secret Service. It was from 2004. They culled through school shootings that had happened. And the single most important thing that they talked about was an investigative, skeptical, inquisitive mindset, which is the most important thing. I would say for all of you that are in training, that is something to really hold on to. You're going to have a lot of people try to proselytize to you about diagnostic statistical manuals and the importance of it. And I'm all for it being a tool for research. But also, we want to approach each child with an inquisitive mindset, a curiosity about one of the questions I start in my mind when I'm doing a threat assessment is, what brought you to this point? Why are you here? And this is just this is more for educators, that ideally it's an integrative, they have a threat assessment team that's integrated, and that they look at bringing in people who can help on the team. And this will be particularly relevant when we look at Goodrum's research, because oftentimes, unfortunately, a threat assessment team is developed by with one or two people in the school having to take responsibility. So if you're consulting to schools, what is recommended is to have a principal as the leader, a school resource officer when necessary, a nurse, a school psychologist, or some kind of mental health person, and then other people that you might bring in as a special ed and a teacher. And sometimes, unfortunately, I often hear when I speak nationwide to educators that there's one or two people that are on a being asked to do these assessments, and that is not enough. The other aspect is that is the question of what's the difference of a crisis team versus a safety assessment team. And the crisis team is really around emergency situations. It's broader. It can, and it coordinates with outside resources, but safety assessments is really about specific threats. And there should be a point person in the school that has been trained in doing these kinds of assessments. And the coordination with local police and school resource officers. What's interesting is how culturally bound we are. When I wrote an article for the International Journal of School Violence, they asked me to sort of check out what other countries are doing. And you can imagine in Germany, there's no allowance to have any police or school resource officers in schools. And we could certainly argue in the Q&A about how helpful that is and who gets targeted with that. But this is just a reminder again for folks that might be educators here, is when you're thinking of a safety assessment team, you also want to look at your emergency room, the guidelines for sending someone to the emergency room, your memorandum of understanding with the police, your internet policy, and your crisis response plan. So many times, and again, for people who are in the emergency room, you might have a district that tends to send a lot of kids to the emergency room, and having there be a policy that's disseminated is really important in terms of coordination. This is, again, if we go back to the Safe School Initiative and we look at what they are examining, what I think is important for us to remember is that many times when there are school shootings, they're coming from within the school. They're current students. It's not people coming from the outside, and that there are opportunities to intervene because 93% had planned out the attack in advance. And many times these students had shown their behavior of concern. At least 3 other people were worried about it. And so I'm going to go over pretty briefly, but enough that to tickle your interest to look more closely at the Safe School Initiative, which you can find from my articles in the Psych Clinics of North America, or through just putting in the Safe School Initiative. And I'll put some at the end. I'll show you some reports that are free for schools. But I'm just going to go over a couple of the questions of the key findings. I'm going to pull out some of them. They have key findings and key and questions. I don't know why they did it that way, 10 key findings and 11 questions, but you know, I didn't write it. So if you are a clinician, though, that's working with a student you're concerned, I would beg you to be familiar with these questions and make sure you document in your chart that you have considered these questions. That will protect you to show that kind of knowledge. So I'm going to focus on 4, 5, and 9. So the 4 is relatively straightforward, but there is no accurate or useful profile of students who engage in targeted school violence. So we all know that, or maybe you don't know, but each time there's a school shooting, someone gets profiled. So if you're in the, for Columbine, it was the black trench coat. For Virginia Tech, it was Asian students who would be identified that would then kind of rise to the top of being. And I was talking about this with with a group of educators, and a counselor told me this story that I thought was really compelling. She talked about, for 2 years in a row, I was asked to do a safety assessment on a student because he wore a trench coat to school and was odd. He had long hair in his face, and I did the assessment and was not concerned about him as a threat. Before he graduated, he came to me to say he was upset about having to wear a blue graduation gown. And this was, she said, his way of opening up to me and coming at us transgendered. It turned out she wore a trench coat to school because she wanted to be more feminine, but due to sort of the cultural component and other reasons was not able to come out. So the profiling has really, hold on, I just lost my clicker. Can you help me find where it go? Ah, here it is.
You can pull this in.
Great, pull it out, thanks. Okay, so anyway, I think it's just, just a good reminder. And, oops, sorry. This, of course, we know most attackers had access to weapons. Usually when they have access to weapons, they are from the home. So I've had many a scary kind of evaluation where you might have guns down in the basement, and you might have families that are saying he doesn't know the lock combination, and you're like, yeah, right. I mean, so, and Dr. Weisbrot, who's a wonderful colleague of mine, has written 2 really good Orange Journal articles, and she has, in her last one, which was in 2020, she has a series of questions. I would say just tuck that article somewhere away. It's a clinical perspective article, but in the weapon access, she says, some good questions, because we tend to say, do you have guns in the home or not in the home, but we might not pursue and follow them up. And does the student have access to a firearm is one, but do they go target shooting? Do they search online for guns? Go to gun shows? Look up how to build a bomb? What would the student think if he or she might do if she or he had a gun? And has threat involved use of another weapon, such as a knife or a bat? So I just think that, this is a good reminder of how important it is to get more nuanced about asking about guns in this kind of situation. And that's just highlighting the idea that in school shootings, they had acquired a weapon from a home or a relative, and that they had a known history of weapon use. And the next important point is, in many cases, other students were involved in some capacity. So many times, there is a sense that you are a rat if you talk with to adults. So this intimately connects to the school climate and whether there are trusted adults that students think that they can turn to if they're concerned. And you may be the trusted adult that someone comes to, either to say, I'm worried about another kid, or that I'm having thoughts about doing something. And so in the 11 key questions, we're moving from the 10 key findings to the 11 key questions. They're the ones that I would call out first is number 3, which is, has the student shown inappropriate interest in any of the following: school attacker or attackers? We have, unfortunately, a copycat mentality. Columbine did not do any service for us in terms of the school shooting word, and that sort of a warrior mentality. And this is a key one: is the student experiencing hopelessness, desperation, or despair? So this is a reminder for you all, if you're in the emergency room and you have a kid who comes in and they're being super aggressive, and of course we ideally do it, but sometimes lost in the moment of someone's combustion, to ask about whether they're suicidal or not. In the psychological autopsies, which were done back in 1988 by David Schaefer, one of the things that he showed is that so psychological autopsies are sort of doing an examination of completed suicides and asking multiple participants about what happened. A third of those diagnoses were antisocial or conduct disorder kids. So not to lose sight of the fact that that there's that these kids that may be outwardly aggressive are also internally destructive. And Sue Kleinbald has a TED Talk. She was one of she was the mother of one of the Columbine shooters, and has a TED Talk and a very compelling book that she wrote called Deadly Reckoning, which was about sort of wishing that she'd been able to see the signs of her son's struggle. Another question is, does the student have a trusting relationship with at least one responsible adult? So we all know, as being in the healing profession, that a charismatic adult is an incredibly life-saving event. And I don't think this is me being arrogant, but I would say, you know, I've had the grace of being able to be that to some of my patients, and that there is a really wonderful exercise that schools can do where they write all the names of the students and then they write all the names of the adults, and they have people put cross-reference to see, are there some kids that are going under the radar? Are we missing making a connection? And that was part of my incentive for starting an advising program, was to try to strengthen that in a structural way. The other question is, does the student see violence as acceptable or desirable or the only way to solve a problem? So that's a key question. Jim Garbarino, was a Boston College professor who wrote a book called Lost Boys. I say that because if you Google the book, there might be one that is something about being lost in space. But this book was looking at under 18-year-olds who had had a life sentence for violence, for egregious violence. And what happened was that there was a narrowing of seeing that there were only a few people that they felt were justified to be alive, and other people they had grievances with, which warranted them killing them. So looking at how someone's idea about what's just and what's not just is incredibly important. And this is just to draw attention to the Safe School Initiative. They have data here that say 75% of the school shooters felt bullied, persecuted, or threatened by others. What I would say to you is, whereas our treatment of suicidal kids is really, I think, well developed and has been researched well, I think our understanding of these kids and our understanding of continuity of threat assessments is fairly, we're in the beginning stages. Maybe in 20 years from now, we'll have better ways of intervening and thinking about it. But when people do nuanced research around the events when someone had the perception of being bullied, often it's the perception of being bullied. So there's a wonderful book called Rampage by Newman, where they do an analysis, and one of the school shooters felt like they were being bullied, but actually they were being bullied. And I've seen that sometimes when I've done an assessment where the student who I'm interviewing is telling me about this, but when you actually do your homework and look retrospectively, this is someone who has persistently gone after other students. And so it's just to say that this is to highlight for us. Okay, so this is something we already talked about, which is that the components of it, ideally in schools, these are the things that we should be doing. If you're a forensic psychiatrist or psychologist, these are the things you want to be seen. And it also highlights, and I heard in the University of Michigan that you don't do this, but in emergency rooms sometimes schools will say, or will tell a parent, you need to go have an evaluation. The child is desperate, the parent is desperate to go back to school, so they come to the ER, or they come to your outpatient office and they say, will you write something that says that this child is safe to come back to school? I would really encourage you not to write that letter. And if we have a chance to talk about if you've had that kind of experience, even modeling how you might talk with families about that. But that is a setup for you, because you don't have the information you need to be able to make that assessment. You don't have the transcripts. You often don't have the individual plan. You don't have the incident report. So you really can't, you don't have the context to be able to have that inquisitive, curious mind. And it's a setup. you know, for those of you who are doing those evaluations, when I teach child fellows or teach people in private practice who decided to do these evals, I tell them to make sure to talk about the limits of confidentiality, that this is not a therapeutic intervention. This is, and just like in an emergency room, you are being like a detective. And anything that they say may be, especially if you're being paid by the school, you may be sharing it with the school. And certainly, this is just also to highlight many times what you may get tricked by when you're in an inpatient unit is sometimes the recommendations are, you know, do you need to have the $1,000,000 question that districts often want to know is, do I need to have this person go to an out-of-district placement? Which I don't know how much it costs in university and in Michigan, but in Massachusetts, that's an $80,000 to $100,000 hit in the budget to put a kid out of district. So they're trying to say, and if you want to have a kid out of district, believe me, if you say that they have sexualized behavior, it's one of the fastest ways to get them out of district these days. But that decision, oftentimes they may ask child psychiatrists to weigh in on. And sometimes when I started my training, I would think that's like the Cadillac, let's get an out of district placement. But many times schools are really doing a good job with being able to hold a student. And when you write that down as a child psychiatrist, if you're in an inpatient unit or an outpatient, you've now pivoted the school in a fight with the clinician and the parent. And so I would really encourage, if you're going to say an out of district placement, to at least do the courtesy of giving a call to the schools to find out what actually are they doing, so you don't get in a split. So I'm going to go through, I'm going to just start with the outcome of the intervention first, and then work backwards and tell you what I would also ask you to do as an ambassador. So, I mean, one thing that's very striking is, which I did not actually appreciate, if you asked me around school shootings, I would think that mostly they were white kids that went into schools and did, and it's true with mass school shootings, but look at the statistic. Black students make up 16.6% of the school population, and they experience school shootings at twice that rate. And that's because those school shootings that are experienced are often individual, targeted to an individual. So they're not indiscriminate school shootings. So we don't hear about them because they're not media. I mean, I think they're media worthy, of course, but they don't rise in the media hierarchy. So, but what I want to start with is, there is and I don't get any kickback from Dewey Cornell, but he's a school psychologist who's devoted his life to doing research on threat assessments. So he took the Safe School Initiative and he operationalized it for schools. So there are over 9,000 schools that have implemented that. And the way that he started with this, he took all of Virginia and he did a controlled study looking at, if we implement guidelines, do a one-day school training, do follow through, do a systematic introduction of threat assessments. So we start with getting the superintendent buy-in. We start with having the teachers be educated around what the intervention is. We let the students know how to report. We have anonymous reporting. We talk about what is the channel of referral that starts with having a principal then make a decision of whether it's transient and substantive, which I'll go over later, and then do evaluations on substantive kids, that this result happens. So what you're looking at is controlling for school size, the percentage of low-income students, and the percentage of minority students. This is so important, you all, when we're talking about disparities in suspensions, that 15% fewer short-term suspensions per year, 25% fewer long-term suspensions per year, and that school authorities are more likely to hold a parent conference and use mental health counseling services than school authorities. So what's really important about that is it's very hard to get any intervention into a school, and it's really hard to do it statewide. So Dewey Cornell's program is statewide in Florida, although it's mitigated some of these results because there's school resource officers in every school in Florida, and it's Florida, and I won't get political here. But I was just saying that if maybe you're a parent and you're in a local school, you might have an opportunity to say, have you thought about Dewey Cornell's program? Often I'm asked to do trainings for school districts across the country. And many times I refer them to, and this is the website, you say schoolta.com. And he will personally reply to many times to the district's emails and help with doing a really good training with, I think, stunning results. And this is just another researcher who looked at this, looking at threat assessments in Colorado, and that there were no disparities in discipline across race, ethnicity, and special ed, which, and this is Dewey Cornell's book. And you can get free forms for, if you're in the emergency room, you could go to schoolta.com and he'll have a bunch of questions that you could ask. That would be a tickler to remember what to ask, or in your private practice. And he looks, so he looked at 120,000 students, 186 assessments. And what he showed was that 70% are transient threats. And so what is transient? Transient means the words are not as important as the context. So if you have, and I think this is good language for us to adopt as clinicians. A transient threat is a threat that's said in the heat of the moment where a kid feels remorseful. And this shows the continuum of threats and how, you know, it kind of graduates up from figures of speech to warnings of impending violence. And so if I look at transient versus substantive threat, I'm just going to go over it again because frequently I'm asked in the Q&A, can you tell me again what you meant by that? So, so you have, oops, sorry, hold on, let me go back. So transient threat, it's minimal risk, it lacks detail, it's made in anger or frustration or as a joke. The info, you want to consider the child's age, the credibility, and the discipline record. So 70 to 78% of almost across the country transient threats. So, and then if you look at substantive threat, it's more direct and detailed, and it could be carried out, or but there have been no preparatory steps taken. But the threat's not empty, and that is when a team comes together, and you get a more labor-intensive kind of event. And serious substantive threat is when it's direct and specific, and it's imminent. So there's serious danger, and you might want to call 911 before you even do a more detailed threat assessment. I'm gonna just ask you guys really quickly. Here's a, so I'm gonna forewarn you guys a little bit of a trick question. But it's a second grader. He makes this picture. He's often disruptive in class. He comes from a troubled background, and his picture is drawn in class, and the family is called and told that he needs an evaluation in the ER to say he's safe to come back to school. Is it transient or substantive? Just transient. Substantive. So nobody's raising their hand. Just help me. Why aren't you raising your hand?
Context.
Context, exactly. You know, if I told you that the reason that thank you, you get the Cadillac outside the auditorium. If he told you that his brother had a gun, and when he got home, he was going to get in big trouble because he'd been a pain in the butt during class, that would be a substantive threat. And we had, I mean, believe it or not, we had a case like this on the East Coast just recently, about 7 months ago, where a student actually, and you all probably recognize it as I tell you this, but a student who actually was in first grade, had a gun in his pocket, and the administrators didn't believe that a child could have that, even though there'd been 2 teachers who had come to the administrator talking about their concerns, that they'd overheard students talking about it. And he dismissed it as, how could he fit a gun in his pocket, right? So this sounds like I'm preaching to the choir in a way, but we need your help, our country, to help So one of the things that just to think about when you are in the emergency room or doing this kind of work is how do you give guidance and support to the family and the student? How do you contain the situation? Making sure you document. There's a famous guy, forensic psychiatrist Goodrum. If you didn't write it down, it didn't happen. So writing down your thought process, I've been an expert witness, is incredibly important. Provide a baseline for future behaviors for a school about when should you alert to bring together people and how are you going to monitor the communication across the staff in the district. I say this to child fellows, you should always put this on your ER visits. It's not possible to make predictions of violence, and this is a time-limited safety assessment that takes into consideration risk factors and aspects of resilience. So that's your CYA that you want to say. I have every child fellow on a report says that. It's a continuous process of evaluating. And this is just, if you put this into your browser, you can download it. It's the United States Secret Service National Threat Assessment Center, or the NASP Behavior Threat Assessment and Management. So it will have the detailed, it's 20 pages, but it will have, if you wanted to get a quick summary of what you wanted to do, for those of you who don't sleep at night, this is a really good one. So it has in it, again, if you're educators, it has the steps that you would want to do on about obtaining approval from the superintendent, establishing a multidisciplinary threat assessment team, reviewing the student code of conduct and discipline, creating a central reporting mechanism, determining the threshold for law enforcement intervention, training school administrator, reviewing the guidelines. These are the kinds of things that I think are often getting shortchanged. So how do we work with schools to create a reflexive process to enhance safety and support families and students? An important aspect is to own the threat assessment process. Whether you want to identify students' threat, you want to evaluate the seriousness of the threat, you want to intervene to reduce risk, and you want to follow up to assess intervention results. This next slide, the 5 cultural characteristics of a culture of safety. This is work that was done by Goodrum, Sarah Goodrum, for any of you who were at my Institute for the American Academy. She's a brilliant sociologist, and I would encourage any of you that are in your child fellowship, look for people that you enjoy their narrative voice when you read. I read her paper and I was like, I need to meet this person. And the reason I wanted to meet her is all along right now, I've been focused on the individual student, looking at the context of the individual student. But I hadn't thought deeply about what is the culture in a school that might be a petri dish for a school shooter. So I'm not blaming schools when they have a school shooter. It's a horrible tragedy. But she went and she looked at a completed school shooting. It was in 2013. There was an 18-year-old white male high school senior in a large urban high school. And he had a record of low-level behavior problems. But he was a student leader in speech and debate club. And he had made a threat. The threat was a poor evaluation. It was a checklist kind of evaluation. It had no, the National Association of School Psychology talks about a behavior response management plan. It had no follow-up with how to monitor this student. And he came back and he killed a student. And so part of the way that the school district didn't get sued, basically, was to allow researchers to come in and carefully look at what was the conditions that might have allowed this to happen. I think it was really brave of the family to do this. And These were the 5 aspects that they talked about. And I think it's also relevant to think about this on an inpatient unit or even in our psychiatric departments, how we manage crises. And they looked at first that staff need to be informed about the current knowledge in the field. There needs to be an environment that promotes reporting, and that oftentimes in schools, staff are confused about FERPA, which is about the protection of, it's like the HIPAA in education and safety. And actually, there's been no school personnel that have gotten in trouble for when they're concerned about safety, speaking to other people, but that gets confused sometimes what happens in schools is they want students to have a fresh start, which I totally get. But there's also something about understanding past history of violence and that this isn't gossiping, it's a safety measure. 3 is about the atmosphere of trust. Think about the supervisors you might have had. We don't show our underbelly, right? We don't show the mistakes we've made to people we don't trust. So is this a culture where you're able to talk about your vulnerabilities? And is there a flexibility? Is there a sense that we're not in a cookie cutter world, but that we can respond in a crisis and that we learn to adjust? So I highly recommend Goodrum's work. She's a close colleague now, and she has a probably all of y'all in Michigan are doing school climate surveys, but I like some of the questions that she has, and I think speaks to the Safe School Initiative. For example, if another student was involved in an unsafe or dangerous behavior, I would report it anonymously without anyone knowing it was me. That's an important statistic to know. If 90% of kids aren't willing to report, that's something that really tells us. And then I like this one, my school has a simple vocabulary about what to do in the event of emergency. The other aspect is training for all staff, having clear procedures. There is anonymous reporting. Sandy Hook Promise does it. Here it's, tell me the name again of.
Okay to say.
Oh, okay.
To say.
Okay to say. I just looked at it briefly, okay to say anonymous reporting, but it didn't, and this is what Michigan's doing right now. It didn't look as rigorous as the Sandy Hook Promise anonymous reporting, which has a 3-year kind of onboarding plan that happens where we know that mostly, and think about this in your practice as clinicians, that most reporting happens on Friday afternoon and Monday morning. So or Sunday during the weekend. So having people from the school that actually monitor can be contacted from the anonymous reporting if something happens is really important. And having multilingual providers and being able to respond to the smaller, like vaping something that might be anonymously reported, like vaping in the bathroom, so that kids have a sense that this anonymous reporting actually does something. Another aspect that I think is really important in schools is about restorative justice. So another practical tip for your patients: if you have a student who's been suspended and they're in your practice, think about their reentry process. Think about what's the language they're going to use when they come back into the school, when kids ask what happened. And restorative justice, which is what a lot happens sometimes, is what rule is broken, who broke it, and what is the punishment for breaking that rule. And restorative justice is what harm was done, what actions would repair that harm, and who is responsible for that repair. So that's another aspect I would say for you all in terms of a practical level in your practice, if you're on an inpatient unit or if you're with your patients on an outpatient basis, is a kid comes in and tells they've been suspended because they, called their teacher or swear or did something like that. Can you brainstorm with them about how they could repair that relationship? This goes without saying, but in some states, what they've done is they've collapsed because some students who are aggressive or have been school shooters have then gone on to kill themselves. Some districts have said, if you're suicidal, you have to go through a threat assessment process. So Dewey Cornell has a really good article. So if you get in that situation where you hear about that, that's a bogus idea to do. This is just shining the light a little bit on what do you do in an ER crisis, the kinds of things that you might want to think about, like how do you approach a kid when they're in a behavioral health crisis, and wanting to know that for your patients that are aggressive when you're talking on the phone with a school, and what are the interventions done to help a child feel safer, and hopefully trying to intervene on having the ER visit be, is this kid safe to be back in school? I also like this question, what to-dos in the moment if you're with a student in a crisis, and thinking about that. If you have a patient that's in your office that frequently ends up escalating and maybe going to the school nurse office, is there other things that you could come up for them? And that's what I spent a lot of time thinking about in the book I wrote with the behavior code, was around, what are in the moment things that we can do in schools to support our students in crisis, and how the school outreaches to contacting the family, because that can really set the stage. So how can you act as a well-equipped safety ambassador in your community? So I just recently heard about Prevent to Protect, which is in Michigan. It's just starting. It's in its infancy stage now, but it's looking at how they can track kids who've had safety assessments, and thinking about how do we use that as an opportunity. So it's in your state, but like I said, it's still starting, but maybe you'll have them come for grand rounds when they get more data to talk more about it. It's Elise Foligno and Frank Straub are the two clinicians that are working on that. I loved The Violence Project. It's a book I just was reading. It was looking at the data from looking at mass school shooters and thinking about the kinds of universal messaging that we can take away as ambassadors. One of the things I loved that they talked about was how important crisis intervention can be. And they had 4 steps, which I think I like them, so I'm going to share them with you. One was de-escalate yourself when you're in a crisis. They had an incredibly compelling story where they talked about a potential school shooter who had come in to see a school counselor and was loaded with a gun, and she de-escalated him, and he was able to give her the gun. So the steps that they say that I think we hear about them, but I appreciated them highlighting them: de-escalating yourself, de-escalating the audience around you. For those of you who are educators, one of the things that I often talk about is getting either the student out of not humiliating the student, getting them out of, getting rid of the audience that might see some kind of, combat. And then nonverbal communication. That's so much of what we say. 80%, any of us who have young kids or grandkids can see that 80% of our communication is nonverbal, and that mirroring it. And so I've had wonderful experiences with educators across the country that talk about their ways of embracing a porcupine, and really showing by body language a level of acceptance. And actively listening, which of course EBT is full of, the validation idea of being de-escalating, and then controlled choice. So I really like this as an ambassador of ways we can think about talking with our parents or talking with each other about a crisis intervention plan. I'm always looking for, and then I also liked that they talk about relationships, which of course we were talking about before, but they talked about, instead of talking about ACE, the adverse child events, thinking about the benevolent childhood experience. What a neat way of flipping that, right? And shining the light on that. And they talked about, does the person you're evaluating have one good friend? Wouldn't that be important for us to know about each of our patients? Do they have a predictable home? Do they have an adult besides a parent that supports them? And you may be that person. And then then there's two other things they talked about, but that, I mean, one was sort of the role of social media and the fact that we have the unfortunate sort of contagion effect that's happening and what we need to, how can we diminish that impact? I also want to briefly talk about Dr. Weisbrot's research, where she, again, her two clinical perspectives are wonderful, but she talked about doing a retrospective with K to 12 students, and there were 157 students, 1998 to 2019. And what I think is important is when we're talking about the transient threats, which are about 80% of the kids that will have made a threat, that many of these kids are actually signaling trouble, that there's something going on, and those are still our children that need to have it addressed. So they may be being bullied, they may have traumatic family events, they may have experienced physical abuse, they may be experiencing verbal abuse. So I did this research in 1996. It's not really switching in terms of that kids who are often behaviors communication, what I say in the behavior code, and that maybe these are kids that are in trouble and need our support, and can we move towards them then instead of expelling them? And no surprise, many of the diagnoses of these kids are ADHD, learning disorders, depressive anxiety disorders, and being on the spectrum. And that many times these students are recommended to return to school. And I see these assessments as an opportunity for intervention, that if you can help access and get them to be able to get the support that they deserve. I don't know about Michigan, but Massachusetts, we have wicked long wait lists for everything. And sometimes as clinicians, if you've done these evals, you can streamline getting their care prioritized. And she also talked about that those students who ended up getting the recommendation for a out-of-district placement or a therapeutic school often had a prior threat history, often had paranoid symptoms, sometimes would be on the spectrum, mood disorder, and and I just want to end with this is a sculpture from a Manuel Oliver, and his 17-year-old son Joaquin was killed at Parkland High School, and he's been a fierce advocate for trying to get support. And so, you know, besides you being an ambassador in all the ways that I was talking with you about, clearly what he has on top of this desk is voting, and how important it is for us to do systemic change. The fact that our country doesn't have gun laws that can protect our children is an absolute travesty. And, you know, I think that our schools are often, I remember when I first started psychiatry, there was a psychiatrist named Comer, and he wrote a book called Rallying the Village. And it was about the idea that schools deserve our support. They deserve us to intervene and to provide the kind of support that will change the trajectory of kids' lives. So I want to thank you and open it up for questions. And this is just telling the key findings, but you're going to get a copy. Do they get the copy of PowerPoint?
I can send it.
Oh, cool. Okay. And this is if you want to get a hold of me. There's my website and my I don't use T or Z or whatever anymore, so at Rappaport doesn't work. But all right. Can I escape this? Oh, stop share, right? And that will allow me to talk to people rather
Yes.
than have that.
If you
Cool.
stop share.
There. Hi, you guys. Hi, Zoom people. I look much bigger now. Okay.
And
I stopped share, but it's still there. Okay.
Dr. Rappaport, I just wanted to preface too, if anybody wants to share a case, just make sure it's de-identified, given that we don't want to share the confidential information, but certainly if there are questions, we'd love to have them.
Yes.
First of all, thank you for the presentation. I appreciate your being in this area because I find metal detectors in primary schools to be a very disturbing.
Yes, what a message, right?
Yeah. So I have a question about the, you mentioned the, the whole Safe Schools Initiative.
Yep.
The process of assessing and has that, well, put it another way. We know that there's, vast differences within our country on things like gun ownership.
Yeah.
And then, of course, between other countries, other industrialized countries, or similar countries. Are there differences in how these shootings and the students who carry them out appear both regionally within the country
Mhm.
as well as between different countries where, of course, they don't appear so
Yeah.
much?
Right. So the question was, just for the Zoom audience,
Yeah.
is there a difference regionally in where, how school shootings happen? And I know with suicide, you can definitely track the suicide rate of, depending on what state has different gun laws. I am not sure, and it's a great question. I'll do the research and get back to you about, just shoot me an email about in states. Although I know, say for instance, Massachusetts, knock on wood, we haven't had a school shooting and we have very more stringent gun laws than in places that people have more access. I think the fact that we have access to semi-automatic guns means that what looks like can happen in our country is vastly different than in other countries. So in China, there's been sometimes mass, there was an event that happened in a preschool, but it was with a knife. So it was harder, and I know, having been in China, it's harder to get access to a gun. So if you restrict access, it makes it more difficult to pull it out. Although we have fallibility. In Virginia Tech, we had the assailant had been in a psychiatric hospital, had been told to have his gun access restricted. There was a delay in double checking that, and he was able to get access to a gun. He also had mandated therapy that didn't get followed through. So there are holes in a system, but it would be far better for us to basically have gun laws that restricted access, which would then minimize the fact that the warrior mentality was so easy to execute. So yeah.
Can I follow up on that? And I just want to know if I'm extrapolating from one of the points in your presentation, which is the percentage of African Americans who are victims of school shootings.
Twice as high.
Yeah. Could it be said that urban shootings are more likely to be kind of what I might call grudge shootings, where an individual goes with a particular individual they want to get after in mind, versus someone who is just like I just want to cause chaos and I want to, that sort of difference between an individual who's targeted versus someone who just wants to cause mayhem.
Yeah. I'm not aware of the research that differentiates, but it's certainly an understandable assumption to think that the school shootings are predominantly done by white males with access to semi-automatics, and that the urban shootings are not with semi-automatics and aren't indiscriminate. So, yeah. Do we have questions coming in from chat, or have I made everybody quiet? You want to put it in your Q&A for those folks that are I see one question on the Q&A, but it might be, how do I get my PDPs?
Yeah, we do have one question
Yeah.
online. The question reads, and it's actually a two-part question. What do you think about asking the clinical question, how long would it take you to obtain a gun or weapon? And then follow it up by asking about where they were thinking.
Wonderful. Two good questions. Probably someone who works in gun health. Let's say the questions again. How long would it take to obtain a gun?
And then follow that question up by asking where they were thinking to get that weapon.
I think there were two and where were they thinking to get those weapons? I think those are both great. This might be someone who works in a public health domain. I'm just making a guess. There's a site at Harvard School of Public Health called Means Matters, and they really transformed the way that I thought about suicide. Anyone who's interested in suicide, in both talking about that in terms of different from when you talk about threat assessments, where there's a long process that many times with folks that are suicidal, it can be 6 minutes to 20 minutes, which is why it's so important to kind of be able to help with those dysregulation, dysregulated people being able to find ways to regulate themselves, and why having access to a weapon is so dangerous with suicidal folks, because something that could have been transient now becomes something permanent. So that's would be my guess, that those two questions are coming from someone with a public health background. And I'm just going to say them again because I think they're really good, and I'm going to pass them on to Dr. Weisbrot. How long would it take to obtain a gun, and where are they thinking to get the gun? I think they're good questions, and should be added in to a more refined way of drilling down and sort of coming in, you know. I'm sure many of us know that when you're talking to teenagers, you don't want to you want to stay with sort of a flat, restrained affect. And this is a way of sort of normalizing, like, oh, you know, where were you thinking of buying a gun? And, you know, how long would you think it would take to get a gun? That those are questions that sort of assume that they're going to probably be getting a gun, which I don't know if you all are familiar with Shay's work, SHEA, but he does wonderful work with asking questions about suicidality. And he talks about sort of the gentle assumption, like, oh, instead of asking someone like, you know, have you taken your medication? Sort of saying like, have you missed your medication? You know, how often do you miss taking your medication? So assuming that they're probably going to miss their medication, and that has that quality of it, of having a gentle assumption that would walk it through. Yeah.
We have another question online asking about your thoughts related to guidelines for media reporting around school shootings and how that could potentially minimize some of the contagion effect.
Love that question. I'm writing down. So the question was guidelines for media reporting. So some of you might be familiar with suicide, that there was a real push to be able to say that if you report suicide in a certain way, it creates a contagion effect. So that had a profound effect. And media reporters really took responsibility for not sort of making someone who was suicidal sound like, yes, they were the class president and they, you know, were the star football player, but being able to embed in it that there was there were mental health struggles, and not glamorizing someone. And there's actually, hold on, and we unfortunately don't do that in the case of media, and people get remarkable exposure where they're actually, as a school shooter, often thinking about releasing information, and they're inspired by the Columbine shooters and the basement tapes that happened that fortunately have been taken off now. So there's a very there's a man who lost his son to a school shooter, and did a Tom Treves, Treves, and he did a TED talk called No Notoriety, because he was stunned that here his, and I do think sometimes now the media is making more of an effort to highlight victims that have been gone, you know, have been killed. I remember with Matt McConaughey, when he did the White House, wherever he went to talk to Congress and try to talk sense into them, he brought the green sneakers that had been, you know, obliterated by a semi-automatic gun to try to plead for some mercy with passing laws that would make sense. So I do think now there's more of an effort to humanize the loss, but it's not enough. I mean, why don't we show, if we're gonna glamorize the person who, or not glamorize, but, you know, make them so prominent, why wouldn't we show the carnage that happened? I mean, I don't want to see the carnage, but I think it would probably, even the last statue that I showed, I was just reading about in Parkland, Scott Peterson was the policeman who didn't go in. And so there's been a suit against him. So he was the school resource officer who didn't go in. And even though I'm in this work, I did not hear for working in the student, the level of what happened to him, until I read an Atlantic article just 2 days ago, and it was devastating. I can see why his father is trying to hold people responsible to change things. So only thing I can think of is that I don't know how we would study this since it's a low incident event. I don't think we can show the copycat in the same way. So we know, say, for instance, April 19th is the Columbine, and we know that there are times when educators are more on alert on April 19th because of the Columbine copycat. But we could show with Cynthia Pfeiffer's research that if you covered a suicide event, that there would be a higher uptick in suicide in the surrounding areas. And they also were able to support or negate having classrooms where you'd say, don't kill yourself, that wasn't a helpful intervention, that there would be an uptick in kids feeling suicidal. So I guess it's a call to researchers to get creative with how we would do it, or to hope that, but I don't know how to, I don't know how you can do it in such a, I'm not sure. But I think that's why it hasn't happened, is because we had researchers who were able to show the difference and make it sort of a moral thing. So I know some people are coming, and certainly I feel the same way, that we are trying to support that not happening, but it's still a ways to come. And maybe that's showing us, like when I was saying that suicide is a more developed field, and we have more, all of us probably have more comfort. That's something we all get, is suicide assessment training, most of us as clinicians, and it's not as much that we would get a threat assessment training. So that's evidence of sort of where our comfort level is, and where the field needs to go. So thank you. Yes, Kate.
This might be a difficult question to answer, and I'm sorry, but when we're thinking about the media reporting about mass shooting events, oftentimes there's a big over attribution to psychiatric diagnoses.
Yes.
So like in Parkland, there's this big discussion around the perpetrator having autism spectrum disorder and over attribution of that incident to that diagnosis. And so in your work with educators who may or may not have that same experience, how do you navigate these conversations around nuanced discussions of mental health and mental health diagnoses and prevention of discrimination related to psychiatric diagnoses in the school system, or over responsiveness to those diagnoses and risk and threat assessment?
I love that question. Thank you. So let me just say it for the Zoom audience. The question was, what about the idea that maybe we're over ascribing mental illness sometimes with the school shooters? So looking at Parkland, that maybe there's some thought that he might have been on the spectrum. Certainly with Adam Lanza, that was a concern with Sandy Hook. And are we stigmatizing those people with those diagnoses? I like what Dr. Weisbrot talks about, which is autism plus. So that, because even I just had some speakers, Parents for Peace, that are working with extremist kids and helping them not be as extreme and migrating that way. And a disproportionate number of those students are on the spectrum. And I like the language of Autism Plus, because it says it's not just the autism, it's the, as we were talking about, some of the, it's the warrior mentality, it's the focus on guns, it's the description of the child that I was talking about who ended up killing another student, that there were elements, not because the student was on the spectrum, but this kind of interest in school shooters or interest in murder and that kind of thing that did it. So I think this is an age-old problem that we've had, which is when there is a mental illness and a murder, that even in the adult population, that many people who have mental illness will feel a certain amount of shame that somehow this implicates them for having the mental illness. And, yes, in Columbine, he wore a trench coat, but there were a lot of other things going on besides the trench coat. And with Adam Lanza, there were many more things than being on the spectrum. And same within Parkland, that's the tip of the iceberg. So I think that's what I would say to an educator is, it's autism plus. And in the clinical perspectives that Dr. Weisbrot wrote, there are 2 references, particularly to that, that idea of, take a look at, so, and school folks could look at it too, to buffer that. Yes, in the back.
Great talk. I was wondering if you could comment a little bit about parental factors or family factors.
Yes,
There was a lot of talk about that, especially with the school shooting that happened in Michigan.
Yep. Wonderful.
As well as multiple other shootings where the guns were obtained by parents.
Yes,
And then
okay.
given to kids.
right,
And also, I think in my own practice, it's interesting to see parents who are likely have high, or kids who have likely high ongoing risk. And parental comfort with gun
Yes.
access or gun
Yes.
acquisition.
Thank you.
Which is very maybe different. or
Yes.
disproportionate, from what clinicians would deem to be safe.
Right.
And also, I think commenting on, both, I think parental assessment possibly, but also, intervention with parents.
Great. So I have almost no minutes to answer that question, but I will give the best I can. So you have your finger on the pulse, which is so important, right? Which is that in the studies that, you know, in the research, Tremolo did an old article before, which was looking at the psychodynamics of school violence. And one of them was around minimization that happens with parents sometimes, and that the effort to try to persuade them can be very challenging. And as you said, if there's a culture of gun use, then the idea that a child has access to a gun can make it, you know, make it hard to make inroads. You know, I do think that having cooperation with the school resource officers, finding cultural brokers that can help with speaking in the same language that maybe a family does. So if they're from a, you know, there's a religious affiliation that they might have with someone that they might trust more than they might with us as a clinician or as within a school can be important. And I think trying to build an ongoing relationship. I mean, I think like when we talk about sex with our kids, you know, it's not a one-time talk, but sort of realizing that you may end up meeting with resistance, but how can you build on their islands of competency, the parents' islands of competency. So like I remember once doing an evaluation on a student where the school was really upset because they felt like the family was minimizing it and minimizing the threat and their concerns about it. And when I met with the family, what I tried to do is to really highlight what they did know about their child and what was important for the school to know, and sort of tap into their sense of expertise, and then be able to kind of come in a different way to suggest support. So, but what I don't want to leave you all with is none of this is easy, right? These are complicated situations, sustained effort, coordinated effort. There are roadblocks and obstacles, and yet at the same time, all of us who love and care about our kids know that this is something we have an obligation to try to make a difference in supporting the families and the children. So, yeah.
Dr. Rappaport, on behalf of the department, thank you so much for such a compelling talk and for really the call for us to serve as advocates to really be aware of this risk and support youth and families.
Come up here and tell the Zoom people too.
Thank you. Thank you.
So he was saying that just please be advocates for our children. Thank you.